This is Beyond Type 1, and my name is Ginger Vieira. I've lived with type 1 diabetes for a couple decades, and I have the pleasure today of interviewing Dr. Kristen Wanyawu, and she is an ophthalmologist with a lot of experience in supporting people with diabetes. Welcome. Thank you for your time.
Oh, awesome. Thank you so much.
Could you tell me a little bit more about your background and where you're at today?
Sure. So I am a health equity researcher at Yale. I'm also a vitreoretinal surgeon. And I became interested in diabetic retinopathy after learning a little bit about kind of the prevalence of the disease and really understanding that there were deep disparities, racial and ethnic disparities in who has diabetic retinopathy, who goes blind from diabetic retinopathy. And when I started to research it, we didn't have a lot of answers. And it seemed very, it seemed like just something that people knew, but we didn't have a lot of answers. And I did my training at University of Michigan. I'm from Ann Arbor. And then I trained in vitreoretinal surgery in the west side of Chicago. The extent and severity of disease that I saw, the differences between those areas was really stark. And I said, I have got to get to the bottom of this. And I really started reading about it and asking questions. And that led me along the career path that I am today. So I have a lab. I have the Site Saving Engagement and Evaluation in New Haven lab. It's in New Haven, Connecticut.
Okay.
And we use quantitative, so big data, number crunching, qualitative methods where we ask community members about what we can do better from the academic side and from a research side to support folks that have diabetes and getting eye exams. And then lastly, we build solutions using methods called implementation science. We know that if you get your eyes screened, you're less likely to go blind. We know that. Research is done, old, figured that all out, but yet and still, we're just not doing it. We're not able to implement it. And so the practice of implementation science is saying, okay, how can we build structures and systems in place so that people are more likely to do the things that we know are best from them, from the evidence that we have in the literature. So I spend my time doing that. It's about 2/3 of my time. And then I see patients a day a week, and I do surgery, and I get to do cool things like this. So it's a fun career. It's a fun life.
Yeah.
I was.
Yeah,
I was in the operating room this morning, so I had to turn off my operating room brain and then start chatting, which works out. So the reason I chose retina surgery, some of the most complicated cases that we do are diabetic retinopathy cases. And so if we, take an aside and talk a little bit about what we call in medicine pathophysiology, or how diabetes impacts the eye. So what happens is when you have high blood sugar in your whole body, you get a level of inflammation in the body. And so what that inflammation does to blood vessels is it makes it more difficult for them to do their jobs. And so if you think about what our arteries do, they bring oxygen to the tissues. Most of our tissues in the body need oxygen, and the retina is actually one of the highest oxygen consuming tissues in the whole body. The retina lines the back of the eye so that you are able to see. And so what happens with those retinal vessels is that they bleed and then they break because of this inflammatory or this inflammation that comes from having high blood sugars. And so what happens is they make abnormal blood vessels. And then the vessels that are there, they open up, just the little cells on the sides open up, and the fluid that's supposed to be inside the vessel actually comes out. And that's something that we call diabetic macular edema. So that's the swelling that's in the center of the vision. And then those abnormal vessels that grow are actually what are called the proliferative diabetic retinopathy, or neovascularization, it's sometimes called. And what those are is abnormal vessels from that inflammatory environment that grow. And the problem with those vessels are, I always say, the only time you're supposed to make vessels in the eye is when you're in the womb. Anytime outside of that, it's going to cause problems. Whereas other parts of your body, new vessels are great. So like if you have a heart attack, great. If you have a stroke, great. Yep, make new ones. Eyeballs, not so much, because it's just not designed to do that. And so what happens is those abnormal vessels, they grow, and then they grow along the back of the gel in the eye, which is called the vitreous. And that's where you get something called a tractional retinal detachment. And those abnormal vessels can grow, and then they pull off the retina. And that's where you really start to get some of the blindness that comes from having diabetes in the eye.
Okay. And
that's what I do. So I can fix that surgery.
You will fix that. Congratulations. Yes, that's quite a skill.
But I always say that my research is trying to figure out how to put myself out of business because those surgeries are really hard. They're really complicated. As you can imagine, how I describe vitreoretinal surgery is operating using tweezers under a microscope, underwater, pulling tissue paper apart. And so those are the surgeries that we do. And it's complicated. I love it. It's, unique and it's something that is a wonderful skill to have. But a lot of the eyes that I operate on, that blindness that I'm trying to prevent is preventable. And so that's why, the work I do is about screening. It's about how to get people screened, how to get people to resources when they don't have them. How do we counteract some of the inequities in the system that are built in so that we can make sure that people have access to the eye screening and care that we need. At the very early stages of diabetic retinopathy, there are no symptoms. So the way that you are experiencing the world is probably the way that you've always experienced the world. And then we look in the back, whether it's through a camera or whether hopefully through a dilated exam where we really are looking and we see the changes. So what those changes are, like we talked about, we can see the abnormal vessels, we can see some bleeding, we see exudate. So we talked about how those vessels, they don't work well anymore. They don't hold in the fluid as well as they should. So we see signs of there being fluid in places that there shouldn't be. And those signs are called exudate. And what I like to think of it as, like if you have a puddle and the puddle dries up and you have the kind of the residual that's left, the exudate is that it's telling us that something is leaking, something is in a spot where it's not supposed to be. And so those are the signs that come early. So when we talk about the stages of diabetic retinopathy, so the very first thing is there's nothing. Everything's fine. We don't see anything. This pristine retina. You see, I'm a vitreoretinal surgeon. I'm like, it's beautiful in there. There are no problems. Exactly. And then after that, the next stage is you get these little outpouchings of the vessels. And so remember, we discussed how it is the high blood sugars and then that inflammatory environment in the whole body. And what that does is it damages those blood vessels. And so they get tiny little outpouchings. And sometimes we'll see a little bit of that. And that's that very early stage. Then you get kind of a few little bleeding spots in there. And then you get the yellow, the exudates. And then from there, you can get those abnormal vessels. And then you can get the retina that starts to tent up and otherwise. And this is, the retinopathy that I'm talking about.
Okay.
Diabetic eye disease manifests itself in other ways, but this is the one that we are, the most concerned about because this is the one that if we find it, there are some changes that we can make. So if I find someone that has, mild, maybe those little outpouchings, I can talk to my patient and we can talk about what room there is in their blood glucose and is there room to try to change things. And, you all are familiar with the technology that's coming, forward. Is the pump that something that makes sense for them? Because we've seen a lot of, glucose control do really well with that. Exactly. Like, so, what does that look like? Are there options for you? I communicate with their team. The team that takes care of their diabetes to see if there's room there. Another thing that's important to know, another thing that's important to know is that the longer you have diabetes, the more likely that you are to have these changes. And that is just because of what happens with the environment in your body, right? Even if you're doing the very best, you may end up with a few little changes, which is okay. But we know, like you were saying, the tighter that you can get that window, the more comfortable the body is, and the less likely your vessels in your eye are to have those changes. But as you have the disease further and further along, it becomes more important. So that's why we say type 1 folks 5 years after they're diagnosed, because you need the time to develop the problems. And then type 2, because of the way it manifests and because people will often have those high levels and not be aware of it, because of how the body responds. As soon as you get diagnosed, you're supposed to find somebody to take a look at those eyes because, sometimes I'll diagnose diabetes in someone by looking in the back of their eyes. It's not as often these days, especially now that they screen, but type 2, you can definitely do that.
And because it's important to note that type 2s it's not uncommon for your diagnosis to come years after you might have already been in stages of diabetes versus type 1 is diagnosed pretty quickly. So that's why there's that difference. An example for why it's so important. And so I have friends who have had, they didn't know that they had retinopathy until they started having blood in their eyes, blocking their vision. Can you tell me where is that in that whole inflammation process you described?
Right. So that is way far along. I always say if you're starting to get symptoms, and these are the unfortunate symptoms where, people will give stories of the blood streaming down, or their vision will turn brown, or they'll see showers of dots. And so those are those abnormal vessels that are bleeding, and actually bleeding into the gel in the eye.
Okay.
But
Abnormal, but
even then, there's still room. Even then, there's still room. So, we prefer to get you where I see a few things, and we can talk about it. We can manage your blood sugar. But if you're starting to have those symptoms, we have laser treatment. And we should spend a little time talking about laser, because laser is very scary to talk about, right? Like the laser treatments. And so I think it's important to really talk about it, because that is the gold standard treatment. For 40 years, we have known that laser treatment decreases the likelihood that someone goes blind. And so if you have a retina surgeon, or someone that takes care of diabetic retinopathy, that sees really bad diabetic retinopathy, that is our gold standard, because we save vision, and we've been saving vision during laser for years and years.
And that's the biggest message. You go to the eye doctor, you can save your vision. You're not doomed to lose your vision just because you have diabetes.
Yeah.
If you get to the eye doctor and get the care you need.
Yeah.
Yeah.
And before that, before all of this, before, the pioneering scientists tried all these things, it was, right? It was something that if you had, diabetes, that's just something that happened. And so now we're so fortunate to live in an era where we have that. And now, I know that some of the folks watching will have experienced injections in the eye. So there are medicines that we inject in the eye that are called anti-VEGF. That's the class. And so we talked about the inflammation in the body and in the eye, and what it makes in the eye is called VEGF, is vascular endothelial growth factor. And we inject a medicine that is anti-vascular endothelial growth factor so that it combats it. Now, what we talk about with that, though, is that it's a short acting medicine. And so it's not something that can give long term. So a lot of times when I see those abnormal vessels, I want the laser in, because I want it to just relax the eye, calm down. And then sometimes we'll do the short term with the injection, because the injection works very quickly. Okay. I think another point here is some of the work I do is qualitative work, which is asking questions and getting answers about folks in our community that are at high risk for blindness because of sociodemographics or otherwise, just, who they are, where they live, because that's actually, one of the big factors in diabetes care. Yeah. And so we ask a lot of questions about, what keeps you from the eye doctor, and what's happening, what's in the way, right? What's in the way? What are our levers? And then also what makes you go? What are some of the things that spur you to want to do this? I always talk to my lab about, like, how can I make this like the next iPhone, right? Everybody wants to get the next iPhone. Like, eye exams aren't nearly as fun as an iPhone, but is there anything in there that I can do so that I can say, yeah, I got to get this thing, right? But a lot of people's experience in this, there's familial experiences. And then I hear a lot of people say, well, I was doing okay until I got that laser, right? Or I was doing okay until I got that treatment. And I think what's really important is that once you're at the end stages, like we talked about, you have those abnormal vessels. I always tell people your eye is kind of coming down the roller coaster. And what I'm trying to do is catch it.
Okay.
And so sometimes when you treat it and it still goes. And it scares people because it was a trajectory and they may not have seen it, right? And so we talked about it. You can still be seeing fine. And then I look in the eye and I'm like, oh my gosh, these things. And to me, it looks like, a warning sign, because I have seen, the end stages of blindness. And I'm like, we got to take care of it.
Yeah.
And then, but what I like to talk about is, we're trying to save as much vision as we can, but this is a really serious issue. And I hope you like me, because we're going to see each other a lot.
Right.
Because there's a lot of treatments when you get to that point. Yeah. You come a lot, you get to learn a lot about people, but there, one of the things that we've learned, and we talk to our participants and we talk with a community member. So we all kind of digest the information that comes from these interviews together. And what she noticed is that something that some of our folks with severe disease were able to find was hope. And that hope was able to help them with the fear.
Right.
Because it is terrifying.
Yeah. Yeah.
It is a terrifying experience that only a few people in the whole world will understand what that is like, right?
And I
To
mean, again, I have some friends who have gone through, they're at a point where they're really losing a certain percentage of vision. And because they endured that treatment, which is stressful, and you have to go once a month sometimes, and it's anxiety ridden, and they have regained their vision in some cases completely. Like it's worth going. It's your vision.
yeah.
And all my appointments up until now have said zero signs of diabetes in my eyes. So I thought I was, kind of in the clear. And because of writing about diabetes and interviewing experts like yourself, I learned that you really still need to go every year, no matter what.
Every year is a great benchmark. And if you haven't been, go.
You've done a lot of research in health equity. What have you seen in your research and your work with patients in how diabetes eye diseases affect Black Americans compared to other populations?
Yeah, so when we talked about it at the beginning, I mentioned that that is how I came to this work. And I
Right.
looked at the prevalence data through this cross-sectional survey, which is called NHANES, and they said, yep, Black people have more diabetic eye disease and more severe stages than everyone else. And I looked in the literature for the follow-up, and I didn't see a lot of follow-up, and I didn't
Mhm.
see any answers for what is happening. And, when we put it in this context, we have to put it in the context of what we're learning about healthcare. And I love that we went through this horrible period of time, which is the global pandemic. But for health equity, it really taught us a lot. It really taught us a lot about inequity in the system. And our system is not designed to give access of care to everyone equally. It's just not. And I think the way that we have to frame it and the way we have to talk about it is that how can we innovate and adjust our systems to include these folks that are missing? And
Mm.
so Black Americans more likely to go blind, more likely to be diagnosed at later stages. And so, what does it look like to engage? What do our systems have to do to change, to do a better job at allowing this group of folks to be able to approach their best health? And I think some of the things that our work has done is we really have tried to think more holistically. There's something in public health that's called the social ecological framework, right? So it really starts at the human and then spreads outwards. And then you say, what are the levers that are helping? And then what's in the way of folks getting their care? And I think some of the things that we always have to address, particularly where we're talking about Black Americans in America, is that there's this whole legacy of racism that pervades just the beginning of society, right? Slavery, a whole thing. And so then growing from there and systems that were steeped in that, and then growing from there. So we have to figure out how to adjust our systems to be more equitable. And then also we have to prove to historically excluded populations that we're actually going to do the right thing. And I
Yeah.
think COVID-19, we had to do that. So we had to put the facts in trusted leaders' hands. We had to put the proper materials in places where people could access those materials. And I think that, that model is something that's really important. So for our work, we talked a little bit about fear. We talked a little bit about emotional context. And, if you add that other layer of Black Americans, there's a very big, very recent history of discrimination where people are worried about being tested and not being taken care of well.
Mm.
Right, it's not too far off where my grandma used to wear a full suit to go to see the doctor. Why
Oh,
did she do that? So they
oh,
would take good care of her.
right. Yeah.
Right, so that they would know that she was upstanding enough to be worth taking care of.
Right.
And that's not far off.
Right.
Right, that is still in recent history.
Yeah.
And so I think we have to begin, okay, what are these levers and what are these systems? And I also think what's important is we have to get the data to really ask those questions. So we have to be able to ask ourselves, okay, how are our patients being taken care of? And when we break this up by race, and when we break this up by ethnicity, or however else you're going to chop it, are we doing a good job
Right.
by our community? And if we're not, then we need to include community and asking questions about how we can do a better job. And it's not community's fault. I think there's also a school of thought that's like, that's like,
Right.
oh yeah, you know how they are,
Right.
right?
That community ought to just know they should be coming to
Yeah, right? Are you
but
kidding? Like, what
not
is
if you
going
haven't
on?
taught them that. Yeah.
Exactly, which is inappropriate because who has the power in the system are the systems, right? The
Right.
power and the onus and the resources are with us. So it's like, how can you help elevate populations by supporting them from folks from the outside? Because it doesn't exist within the systems yet.
Right.
And so what does it look like to bring folks that say, all right, we're good at this. How can we work together to do this? So Yale does that by having a steering committee that's 20 years old, and it has bodies from community organizations and academia.
Okay.
And they sit together and we talk about research projects or what's happening next to make sure it makes sense. How are you going to make sure that what you think is important can get on the list of these at-risk communities that have a lot to think about? So how are you going to figure out how you can get into that prioritization and into that structure so that we can make it important? So, I think those are the types of things. It's asking the questions, it's doing the hard work, it's acknowledging, historical references, and then having the humility to shift and change going forward, right? And to be like, to be in fancy places and be like,
we've made a mistake here. We made a lot of mistakes. Let's try to
we're not doing well.
Yeah,
but we could do better.
Right.
And be kind to yourselves as you're walking along this path. It's really important to all of us that you access your best health in whatever that looks like for you.
Well, thank you so much. And I really appreciate your expertise, but also all the energy you're putting into helping people with diabetes save their vision. So thank you.